All right, good morning, everyone. Today is Thursday, November 2nd, and this is the County's Health and Human Services Committee. I am joined by Councilmember Lutke, and Councilmember Sales will be here any moment. There are two items on the agenda that we will be discussing this morning. Both are briefings. The first is a briefing on the Community Health Needs Assessment Implementation Plan, and the second item is the implementation of the Federal Emergency Rental Assistance Program funding, ERAP, and an update on where that stands. But we begin this morning with the Community Health Needs Assessment Implementation Plan. And let me just say at the outset, I am intimately familiar with how important this work is and how comprehensive it is and how many different stakeholders are involved in making sure that this needs assessment is effective, timely, and helpful to all. So to all the volunteers, to all the partner organizations that worked collaboratively, we say thank you. And thank you, Dr. Rogers, for your continued leadership. And so with that, I will turn it over to Ms. Clemens-Johnson to just tee this up at a high level. And then Dr. Rogers, I'll turn it over to you. I believe there is a presentation.
Good morning. Thank you, and thank you to our attendees this morning. So we are here to talk about the Healthy Montgomery Community Health Needs Assessment. It is a local health assessment that identifies 18 key health needs and issues through a systematic, comprehensive data collection and analysis. The report hasn't been published yet, but should be published soon once the Healthy Montgomery Steering Committee votes on it next week. Within your packet, we made some high-level comments about the Community Health Needs Assessment, but Dr. Rogers and his team will really get into the details, talk about the implementation plan. The plan has been a work in progress, I believe, since 2021, and I believe the term that it lasts for is about 5 years with regular evaluation and reviewing outcomes, and then we move to the next assessment. So I will thank you for being here. There's also, I just want to note, the Healthy Montgomery Steering Committee is the local health improvement coalition for Montgomery County. That's also like an effort that's driven by the state, where there is LHICs, as they call them, all around the state. They offer funding opportunities pretty much yearly, depending on their funding. And so Montgomery County has been able to access some of those funds for different projects at time. And Healthy Montgomery is also supported by the hospitals, who also provide a fiscal commitment every year. So with that, I will turn it over to Dr. Rogers.
Yes, good morning. Thank you, Tara. Great overview for today's session. For the record, Dr. Christopher Rogers, I'm the Acting Chief of Public Health Services. And I want to recognize for my colleagues that I have with me today. We have our Director, Dr. James Bridges, and our County Health Officer, Dr. Keisha Davis. And then we also have our Dr. Chung Fu Liu, who is the county's epidemiologist. Sitting next to Dr. Liu is Rita Dang, Senior Planning Specialist with our epidemiology team. And next to Rita is Elizabeth Beck, who is our Program Manager for Healthy Montgomery. And so my colleagues and other colleagues across the department all contributed to the Community Health Needs Assessment. And so it was a collective team effort. So I want to make sure that I recognize them, and I have them here just in case there are any subject matter specific questions that may come about. I may call them to the desk. Next slide for me, please. So the Community Health Needs Assessment for Healthy Montgomery, as Tara mentioned, Healthy Montgomery is the county's local health improvement coalition that is responsible for developing the county's community health improvement plan. Each local jurisdiction throughout the state has a local health improvement coalition. Fortunate with Montgomery County, we've had our local health improvement coalition, Healthy Montgomery, in place for several years. The Community Health Needs Assessment is important to note that it is one key phase of the overarching community health improvement process that we use across public health and community health in order to identify what those priorities are as a community that we will focus on as it pertains to addressing health needs, issues, and barriers. And so as you see on the slide here, phase 2 is kind of what we are talking about here today. We have developed the comprehensive community health needs assessment, and I'll articulate the steps that we went through in order to develop what we know as a CHNA, community health needs assessment. You may also hear the term community health assessment, community health assessment, community health needs assessment. Those terms are used interchangeably. Next slide, please. So what we wanted to do is just talk a little bit at a high level about some of the work that Healthy Montgomery has done over the past several years as it pertains to the previous community health needs assessment that was done. And so out of the work that Healthy Montgomery did previously back in 2016, there were kind of 3 priorities that stem out of those. And you'll see the results of some of that work here on the screen. For example, in 2017 to 2018, we had 10 schools who participated in a local school wellness council. Our epidemiology team also hosted 2 public data workshops around how we use equity and data focus equity in order to improve equity across the county in 2018. Health in all policies. We know that under our leadership of Dr. Davis, the county continues to put a focus on health in all policies, and this is something that stems back to 2019, and we continue to look for ways to broaden the health in all policies work across county government, as well as informing the public about what do we really mean when we say health in all policies, and how can we operationalize that into our work. In 2021, the Public Health Services, we partnered with Fire and Rescue to launch a pilot project, Predict Link Control Project, which was a pilot project that looked to address unnecessary emergency department utilization amongst type 2 diabetic patients. Our epidemiology team, what they did was use some predictive analytic work. They identified targeted zip codes in special populations, specifically African American and Latino populations who lived in these zip codes. And when a patient called 911, and if they have undiagnosed type 2 diabetes, or if their type 2 diabetes is out of control, our local health department receives that information on that patient directly from Fire and Rescue. And we have a team of community health workers that will follow up with those individuals to provide them with chronic disease self-management support, linkages and referrals to help them address social determinants of health, health promotion, health education, a whole host of other services in order to drive down unnecessary utilization. So that's just a few of the accomplishments that Healthy Montgomery has done since the last community health needs assessment. Next slide. So what is a community health needs assessment? I think what I'll say is that it really describes the health needs of the community. And so we use the data that we've collected, which I'll articulate later, to identify what are the significant health needs within the county, and then we use that information in order to prioritize a select few of needs that we can then kind of focus our resources on. Next slide. So the community health needs assessment started way back in 2020, right when I joined the county. One thing I noticed, and I said to Dr. Gales and Dr. Bridges, it's time for us to do our CHNA. And so I got started working with our Healthy Montgomery Steering Committee, which is our local health improvement coalition, for a CHNA kickoff and vote back in the summer of 2022. What I'll also note, which is important here, is that we formed what we call our CHNA Advisory Committee. So the CHNA Advisory Committee is made up of a group of internal and external stakeholders, both members from the Steering Committee as well as interagency and other organizations and community partners that came together to inform the design of the community health needs assessment, as well as to approve our model or the approach that we have used for the community health needs assessment. Really, every step of the way, every key slide that I'll articulate today, the CHNA Advisory Committee had input on that, and we make sure that we got buy-in along the entire process. What I would say is that as of this morning, the Community Health Needs Assessment has been approved by the Healthy Montgomery Steering Committee, and so we are great about that vote. And we will now move the vote to be ready to be published for the community and disseminated largely. Next slide. So I want to just talk a little bit about some of the data collection that went into this, I guess, rigorous evidence-based community health needs assessment. We use the county health rankings as a conceptual model in order to collect as well as analyze and present the data for the community health needs assessment. And what the county health ranking model does, it allows us to see how various factors, health, behavior, clinical care, social, economic factors, and built environment factors impact or contribute to health outcomes. What we did also is that we added a demographic category because the county health ranking model lacks that particular measure, because we know demographics have an impact on quality of life, length of life, as well as health outcomes. And so this is the frame or the lens in which we use in order to guide the community health needs assessment. Next slide. The community health needs assessment, a hallmark of community health needs assessment, or ones that I would say are rigorous, are ones that apply a mixed method approach. We use a mixed method approach for a number of reasons, and some of the reasons here are articulated on the screen. We use qualitative data so that we can gather the thoughts and perspectives and insights from community residents, community stakeholders about what are the health issues, needs, and barriers that they see that exist within their community. We also use a community-based participatory research approach, and I'll talk a little bit more about how we operationalize that in some later slides. But what that really allowed us to do is that allowed us to really put in the hands of the community our recruitment process. It really allowed us to put in the hands of the community who are the participants, who are the residents, who are the stakeholders that should be included in these focus groups and these key informant interviews. We use quantitative data. As you will see on subsequent slides, this is the first time in the county's community health needs assessment history that we had a primary survey. We use quantitative data to assess residents' health needs, issues, and barriers. Then we have other types of quantitative data that we collected, for example, oral health capacity and demand, environmental scans so that we can assess oral health needs across the county, as well as an environmental scan of organizational resources so that we can see, what assets or resources exist in the community already to help address the needs that will be identified. Next slide. There are also various secondary data sources that we have included within the community health needs assessment. We report on the social vulnerability index as it applied to each zip code across Montgomery County. We work closely with the County Department of Planning for this data. Our epidemiology team also used vital records, disease registries, hospitalizations, as well as other federal and state data sets that we analyze to contribute to the findings of the CHNA. Next one. So why do we use a mixed method approach? Well, we're able to validate our results. As we see the same themes show up in the qualitative results, we look to the quantitative results also to see if the same themes, that is, the same health needs, issues, and barriers were also being showed up in our primary and secondary data. So we're able to validate the data. It also allowed us to be consistent. In other words, our data that we have collected is really generalizable to various communities throughout Montgomery County, so it increases that reliability of our results. Also, when we look across our themes that we'll produce in a community health needs assessment, using mixed method results provides better contextualized measures. That is, those measures that we have come up with for those themes that have been identified are more robust as a result of seeing those needs show up in both focus groups as well as the survey data that we have collected. So there's many rationales for why we chose to use a mixed methods for our community health needs assessment. Next slide. So we're proud to say that there are many firsts for this community health needs assessment. We were very strategic back in 2020 as a team, as a Healthy Montgomery team, to say that we need to go to those communities who we don't often hear from, the communities that we don't often hear their voices, let's be purposeful about reaching out to those communities so that we can understand what their health needs, issues, and barriers are. And so we did that. This is the first time that the community health needs assessment included perceptions of individuals, residents from the agricultural reserves, the LGBTQ plus community, community members with disabilities, refugees, individuals who recently migrated to Montgomery County within the past 10 years, youth, and older adults. Next slide, please. So on this slide, what you'll see is an overview of the subgroups that we engaged. So this is really where the community-based participatory research comes into play. And so what we did was we worked with the Community Health Needs Assessment Advisory Committee to identify subgroups that were important for us to conduct outreach, focus groups, and data collection with. And so, for example, for the community members from the agricultural reserves, we partnered with the county's Office of Agriculture Services to identify residents to participate in that focus group. We partnered with Trans Maryland and the Montgomery County PTA LGBTQ plus office in order to identify community members to participate in the LGBTQIA plus community. Matter of fact, we didn't just partner; we really asked them to go out and recruit. We said, we have the facilitators, we have the ability to analyze the data. We'll provide you with culturally competent flyers and recruitment information. Please go out and identify community members within your area that can participate, and we'll do everything else. We partner with the Minority Health Initiative programs to identify members from their communities to participate. We partner with the Office of Community Partnership, Gilchrist Immigrant Resource Center. We partner with the Intellectual and Developmental Disabilities Commission. We partner with the Regional Service Centers and their boards. So we partner with a number of key community groups to identify residents across their communities to engage in this effort. Next slide, please. Furthermore, we had key informant interview stakeholders and organizations. For example, we have representatives from the clinical organizations that participate in Montgomery Cares. We did a key informant interview specifically targeted with them. We had key informant interviews with each of the hospitals. For example, we had emergency room physicians and other professionals throughout each of the hospitals participate in key informant interviews. We partner with the Fire and Emergency Services Commission, Police Advisory Commission, Interagency Commission on Homelessness, Board of Social Services, and the Racial Equity and Social Justice Advisory Committee for the key informant stakeholder interview that involved the boards, committees, and commissions. We also partner with the YMCA, Latin American Youth Center, Identity, and NAACP Parents Council as well to identify stakeholders to participate in these interviews. Next slide, please. So we engaged over 2,500 unique participants to contribute to the Community Health Needs Assessment. So over 1,300 residents completed the primary survey. I think what's important to note about that is we oversampled minority communities. So zip codes where we have a high number of minorities living, we made sure that we collected more surveys from those communities. Over 250 residents participated in our 23 focus groups, 54 stakeholders, 842 respondents to our LGBTQ plus community survey. Over 40 dental providers locally participated in the oral health capacity and demand survey. And we had over 31 stakeholder groups contribute to our environmental scan. And so you can see we have a very strong sample representation of the Montgomery County community. And so we feel that the results are very reliable and valid as we present them. Next slide. So in order to do data analysis, what I will highlight here is that the way that we identified our 18 significant health needs, we did really three primary things. Qualitative sub-things that come out repeatedly as a health need, issue, and barrier. We elevated that as a specific theme underneath a significant health need. and then quantitative indicators from primary and secondary data that were mostly reported by responders as health needs, issues, and barriers. We elevated that and reported those under each significant health needs. And then we use inductive and deductive categorization of data in order to identify the list of 18 significant health needs. In other words, using that conceptual frame, we knew that based on the literature, there were some significant health needs that we may expect to see as a result of the data. And then with the CHNA Advisory Committee, we said, okay, what else is missing here? What else could possibly be significant health needs? And then any needs that emerged from the data that had themes, we identified those as significant health needs. Next slide. So what are the significant health needs for the community? So there are 18 that we identified. 18 significant health needs ranging from access to behavioral health and substance use disorders, access to human services needs, such as those that contribute to the social determinants of health, access to quality dental health services, access to technology, active living, healthy and nutritious eating. Next slide. Cultural and language competency, injury and disease prevention and management, safe and violence-free environment, and all the way down to waste management. And these are listed in alphabetical order. So I believe you all may have received the full report in advance of this session. What we wanted to do is just pull out a few of the qualitative themes and a few of the quantitative indicators listed under each significant health need. And so I'll just go through a couple. For example, under the access, behavioral health, and substance use disorder services, what do we mean by that? So what we heard from the qualitative focus groups and key informant interviews is that the community members identified the use of opioids as a health need issue or barrier. They identified that there was stigma preventing individuals from seeking mental health services. And we saw that information corroborated in the quantitative data and vice versa. So, for example, we know the use of opioids will increase drug-induced mortality. And so that arrow shows that it's increasing over time compared to the last community health needs assessment. We also saw that mental health ER visits per 100,000 is sort of trending down as we saw as a result of this data. Now, this data, I think it's from about 2021, 2020 is around when this data was collected and analyzed. We also see suicide mortality based on the latest results was also a significant need, but it's kind of trending down as a result of this latest data. Let me just pull on a couple other ones. So access to human services. Community was loud and clear that the high cost of living in the area was a health issue that contributed to health needs. We also saw that the number of physically unhealthy days reported in the past 30 days. So people, tend to be getting a little bit healthier because that number tends to be decreasing under the access to parks, public health, wellness, and recreation, significant health need. Access to quality dental health services was clearly on the minds of many of our residents as they completed the qualitative and quantitative data collection. Mobile dental services. People communicate to us that there's a long time that they have to travel to dental services. And we know that there's a portion of the Montgomery County community that has a lower ratio population of dentists to residents. Next slide. A couple more that I'll point out here. So access to specialty and extended care. Affordable urgent care clinics. So the need for urgent care clinics, specifically for the uninsured population, is something that we heard throughout the community health needs assessment. Access to technology. There's been great strides in the county to increase access to technology, but we heard that throughout the community health needs assessment that people lack internet access or households with broadband internet connection. Access to transportation. Transportation barriers to medical appointments came out clearly through the community health needs assessment report and the findings. So individuals reported that there's a lack of transportation affecting access to health care. And then we also looked at from the community survey that respondents indicated or corroborated that identifying transportation as a barrier to health care. Next slide. Some other significant health need themes that I'll talk about: active living and nutritious eating. One that was actually surprising to me here is that participants told us that they would like healthier, low-cost, speed of option or fast food options. So like your McDonald's and Burger King, they say there's no healthy options in the county. And so they asked for that. And we see that playing out in the quantitative data by the increases in diabetes mortality rates. Cultural and language competence. Community emphasized and stressed to us over and over again about the need for more bilingual and culturally competent health and human services providers across all settings that they engage with health and human services care. Environmental health, notable quantitative indicators: lead poisoning in children we see is decreasing. But individuals also mention how housing overcrowding is contributing to environmental health needs. Next slide, please. Injury and disease prevention and management. Your chronic diseases continue to be the top causes of death and morbidity across the county, irrespective of what we experienced through COVID-19 the last couple years. Maternal and early child health. Community said to us that we would like better access to family planning services and information that's needed. And as we see, low weight birth and very low weight births are increasing in Montgomery County. Next slide. And then finally, just the last two significant health needs pertain to social associations of community connectedness, which when we did data collection on COVID-19, you would expect that people were experiencing social isolation, et cetera. And so we heard that from participants. And then in waste management, people told us that, we would like cleaner neighborhoods and parks. And that was a health need or issue in their community. So here are just some consistent themes that we wanted to just pull out and just highlight. There's probably some others that we can include here that we just wanted to summarize for you all here. Next slide. So tying it all together with the health and all policies approach is important as we begin to make progress or continue to make progress, because we have already been doing some good work in the county to make progress on a number of these fronts. And so using a health and all policies approach can really continue to allow us to make progress here. And on the next slide, you'll see how various county departments can contribute to health and all policies to address the health needs and social drivers that we found across the consistent themes within the community health needs assessment. For example, I mentioned earlier around type 2 diabetes, so disease and chronic illness. Health and Human Services partner with Fire and Rescue and Montgomery County Public Schools. And so we are sustaining that pilot program that I mentioned earlier in Fire and Rescue as we continue to work to address type 2 diabetes. Need for cultural language competency in all we do. And so, two agencies across county government that play a key role within that, HHS as well as MCPS. And then you see, for example, importance of public transit accessibility and promoting equitable access. For example, HHS is working with Montgomery County Department of Transportation right now to look at how do we increase dental access in the Hewitt Gardens community. And so that really speaks to a HIAP approach to improving health outcomes. Next. So with all this information, how do we plan to disseminate the community health needs assessment to the community? So there's a couple things that we will look to do. As I mentioned earlier, the Healthy Montgomery Steering Committee officially approved the community health needs assessment as of this morning. And so now that the CHNA has been approved, we'll move forward to publishing that online. So we'll have the full report For the technical folks like me, the folks who may have the PhDs and the masters that want to dig into the whole 200 pages, they can read through the report. But we'll also have an executive summary for individuals who want like a quick kind of snapshot overview of what the community health needs assessment is all about and some of the significant findings. We'll have an executive summary as well. We'll also have an infographic. The infographic will be a one-page just kind of snapshot of all the significant health needs. We're also planning to have a community partnership summary. So a community partnership summary is really like a 6th to 8th grade reading level overview of the community health needs assessment in like this half-page booklet that will be translated into the top county languages. And what we plan to do with that community partnership summary is disseminate it all throughout the community. So when you go into your local food pantry, when you go into your local health safety net clinic, on the table, we would like to have community health needs assessment summary reports in multiple languages so people can pick them up and read them. And so they'll be free of charge. We'll ship them out to community organizations at request, as many as they would like. And so we'll also be doing some press releases and social marketing promotion here this month and into next month. We're planning a virtual town hall later in November, where we opportunity to present the data report and allow participants to ask questions. We're also going to reach back to those groups that participated in the helped us with recruitment. So we'll reach back out to the LGBTQ plus community. We'll reach back out to the boards, committees, and commissions. So all of those groups who helped us with recruitment, we want to go back to them and present the findings and share not only what they told us, but also what the greater community told us about what the significant health needs are going to be. And then we'll do some talk show podcasts as we move into the new year in order to disseminate the community health needs assessment. And then we're open to any other ideas that you all may have or the community may have about where we need to go in order to disseminate the findings of the CHNA. Next slide. So after the community health needs assessment is disseminated, we'll move into the next phase of the overarching community health improvement plan, which is prioritizing. So identifying the significant health needs that as a community that we will look to prioritize. And so in essence, what that does is it takes that list of 18 significant health needs and then narrows it down to somewhere between like 3 to 5 needs and say, here are the 3 to 5 needs in Montgomery County that we would like to put resources around, that we would like to build a project plan behind, identify resources, tasks, etc., in order to move the needle around improving health outcomes. We'll also update the Healthy Montgomery core measures that we have, so those measures that we are tracking as a county to show population health progress. We'll update those measures as well as we set the community health improvement plan. Next slide. So how will we set the community health improvement plan? Community engagement. So we have to engage the community. And so we have we're using the MAP framework in order to do that, which is an evidence-based framework for community health, for developing a community health improvement plan, and underpinning the identification of the health needs or the health priorities is really using a human-centered design approach. And so, in other words, we want to put the community right at the center of identifying what are the priorities and how are we addressing those priorities. And so what we're going to be doing is we're going to be going throughout the community and we're going to be holding forums where we'll present the community health needs assessment, and then we'll ask the community to vote, to rank what they see as the top health priorities for the community. And then out of that vote in person, we'll also have an online vote perhaps. We'll identify the top 3 to 5 priorities as a community that we will identify, and we'll work with the Healthy Montgomery Steering Committee and the MAP Committee and further the community to begin to identify how do we begin to address these? What are the strategies, what are the solutions, etc., to really address these 3 to 5 priorities? Next slide. I talked a little bit about the MAP subcommittee and who they compromise. So the MAP subcommittee includes a group of stakeholders to review the framework, to provide guidance and oversight on development of the community health improvement plan. Next slide. So here's just a summary of what our next steps are. Mentioned Healthy Montgomery Steering Committee has voted. We're going to initiate human-centered design and map in order to drive the community health improvement plan. We're going to have these community conversations throughout the community to identify the 3 to 5 health priorities. And then we're going to continue to engage the community on developing goals, objectives, resources, tactics in order to address those 3 to 5 health priorities. And then out of that community health improvement plan comes supporting cross-sector partnerships, both community-based organizations, interagency, county council, etc., with helping us to address the health needs, issues, and barriers that are prioritized throughout this entire process. Next slide. You go to the next slide. And I think I'll take any questions that you have.
Great. That was comprehensive. I appreciate that, Dr. Rogers. And I know that those 200-plus pages were synthesized into that presentation, but it was very well done. I had a few questions, and then I'll turn it over to colleagues for any follow-up. So one of the things I was most impressed by in this particular report was the intentionality in making sure that a number of our demographic sectors were represented, which I think is a best practice and indicative and will tell a better story, a more comprehensive story, a more accurate story of our overall public health picture. Could you dive a little deeper into how those categories were selected? And then, you know, we are challenged sometimes as local jurisdictions because our federal partners, based on some of the funding we receive, will dictate how we track information at the local level, which sometimes puts us in a box and in a disadvantage because we know one of many examples within our Asian community, there are many different ethnicities and cultures that have very much their own unique set of public health challenges and opportunities. So could you just talk a little bit more about how those were selected and how or if this could connect moving forward to both the state and the federal government to encourage them to have these more robust subcategories?
Yes, thank you for that question. I would say a couple different ways that these subgroups were identified. One is looking at the previous community health needs assessment. We wanted to identify what particular community groups that participated in the previous CHNA, and so we perhaps wanted to mirror some of those groups. We also wanted to look at kind of the groups that we knew based on experience, based on the literature, based on the data that we already have available to us, many of the reports that we put out, what particular groups tend to be the most vulnerable, what particular groups tend to experience greater lack of access to care, have greater disease burdens, for example. We also wanted to hear from those groups that we knew we hadn't heard from before. And so when we looked at the previous community health needs assessment and we looked at the data based on what we knew as particular vulnerable groups in the community that had high particular prevalence or incidence in this particular area, we said to ourselves, so what's missing here? And then we knew, for example, that the LGBTQ plus community was missing. We also knew that there were some groups that the county that wants to increase priority focus on, like the LGBTQ plus community. And so we wanted to provide more data for county government and for the community as to what the particular health needs, issues, and barriers are, because we knew that there may be a gap within our reporting or within our existing reports. And then we went directly to the CHNA Advisory Committee, and we asked them, like, what's missing? What are you seeing from your vantage point? Are there other subgroups that we must include? And then from their own vantage points, they also identified particular groups. And then we had to balance that against the budget, against resources, right? And so I would confidently say that we were able to include all the subgroups that we set out to as part of the community health needs assessment. And I would say yes. I think the subgroups that we have identified, the data that we collect on a local level, should and can be used to inform resource allocation at the state and federal level. all too often, we may see some of these subgroups or some of these zip codes in Montgomery County who we know that our local data shows health disparities, shows health needs, is missing from federal dashboards. It's missing from state level dashboards. And we know that if those communities don't show up in the federal data set as showing a particular need, such as the ratio of primary care providers to residents, then federal and state resources may never actually get to that community, right? And so, at the health department, HHS, we've already engaged in a conversation with MDH, as well as with the county executive's office in HRSA, around the need to ensure that the local data is being shared back with the state data, with the state Maryland Department of Health, and is making it back to the federal government so that they can update kind of their metrics, that they can update their regs to ensure that the communities that are most vulnerable, based on the data that we're collecting at local level, is actually being reflected in the federal dashboards and the state dashboards, because we know that's what drives resources.
Yeah, I couldn't agree more. So often, too many of our constituents don't see themselves in the various boxes, and you can't check more than one sometimes, but we self-identify in so many different ways, and that has major public health implications. So I think we can and should be a leader in that space, and build on this. Related, so this of course will now serve as baseline public health information moving forward, and that's important, and will continue to evolve. But I think that sets us on a more appropriate course, and I really want to acknowledge Dr. Davis, Dr. Rogers, and their entire team. This was something Dr. Davis talked about in her interview to become our public health officer, is making sure that we do a better job of seeing our community, and I think this reflects that. Speaking of community means different things to different people, and I think I counted, Dr. Rogers, and you appropriately used that term multiple times throughout your presentation. From a public health standpoint, how do you define community? What does community mean to you? Because it could mean many different things. It could be geographic, it could be demographic, cultural, ethnic. What do you mean, generally speaking, as you continue to refer to the community and its engagement?
Yes, thank you. For me, and I think in public health, a community means a group of people who share a similar story. Mm-hmm. And so when we identify who are those groups of people that share a similar story, then I have to operationalize that. And so how do I operationalize that? So when I identify the group of people who share a particular story, how do I actually reach those individuals? And so for me, an example that I like to always give is that, I want to be able to go into the apartment complex within Montgomery County, or go into a zip code in Montgomery County that has a high proportion of minority individuals, or Latino or African American individuals who all share a similar story, maybe because they live within that apartment complex. And how do I pull them out of their homes so that we can actually listen to their lived experiences? And then based on their lived experiences, how do we use that information in order to understand what the needs are, in order to drive strategy and to drive solutions based on what they identify as solutions or strategies to meet their particular needs? And so it starts with identifying a group with that shared story. It can be based on race, it can be based on geographical location, it can be based on some type of lived experience. And so that's how I would define a community, and then operationalizing that community. Community may also mean organizational stakeholders, right? It could mean, for example, all of the public health, all the organizations within Montgomery County who specialize in public health, or it can mean all the organizations in Montgomery County who specialize in, advocating for resources that improve infant mortality. And so, again, they have a common story, they have a shared experience around improving infant mortality, within the county, and so that can also be considered a community. So community operates on the intrapersonal, interpersonal, community, and organizational levels. As we look at each one of those levels, who has a shared story and what their stories are, and really being able to kind of carve out that particular community to listen to their unique needs.
I appreciate that, and the reason I asked you is sort of a tee up, because when we say community, we're not just talking about geographic community. There are different needs, complex needs within zip codes that need to be uplifted and acknowledged, and so that micro level engagement, I think, is particularly important in the public health space. I have one question, and then I'll put myself one more question, and then I'll put myself back in the queue. We are tracked, and we were last year, as the healthiest county in the state of Maryland. But that's a little bit of a misnomer. We're proud of that. I think it's accurate. But it doesn't completely tell our story. And as you dig deeper, the lack of physical activity being on the rise, the increase in mental health challenges. Could you talk a little bit about sort of that paradox of, on the one hand, at a macro level, it looks like we're doing okay in certain categories, but as you dig deeper and as this assessment acknowledges, that doesn't totally tell the whole story.
Yes, thank you for that question. Thank you for that softball, because it actually underscores the importance of making sure that we stratify the population based on different groups who are experiencing, who have certain lived experiences. So yes, the individuals who may contribute or that responds to the surveys that assess the health status of Montgomery County at a national level may not be the same individuals who respond to local efforts to collect that data. And that's why it's so important to have local level data collection and using that local level data in order to inform what the state and what the federal governments are doing, because at the local level, we're able to go into those particular communities and really understand and really be able to assess using rigor what their particular needs, issues, and barriers are. And so as we dove a little bit deeper at the micro level into particular communities, into particular subgroups, we were able to see that, yes, in fact, there are still existing health needs, issues, and barriers that may still exist, even in light of Montgomery County being the healthiest nation in the county. I mean, there are 1.1 million individuals in Montgomery County. So totality-wise, yes, we can say compared to other counties we are, but there are still disparities that exist, and this report highlights exactly where those disparities are. That's exactly why we developed and we presented the findings as such. We purposefully presented the findings for subgroups because what we wanted to do is we wanted individuals to really go to a particular section that most interests them. So maybe there's a particular group of individuals that they are most interested in, and what are the particular health needs, issues, and barriers as it pertains to that particular subgroup. And so as we put all the information together, we were able to elevate these key themes and these key indicators to identify that here are the significant needs across the entire sample population. And so I would say that the importance of making sure that we stratify the population in order to dive more deeper into what exactly the needs, issues, and barriers are is the reason why we can say that there's still work for us to do in keeping Montgomery County as a healthier nation in the county, in the nation.
Thank you, Dr. Rogers. I'll get back in the queue to talk about the health and all policies and where we go from here, but I will now yield to my colleagues, and I'll just say up front, as I've said before, both of my colleagues selected as their lead issue significant issues that have significant implications for overall public health, and it's a credit to both of them for their leadership in that space. So I will turn to Councilmember Sales and then Councilmember Lutke.
Thank you, Mr. Chairman, and thank you, Dr. Rogers, for this comprehensive report. I know we just got a little taste last month during the briefing. And so as the lead for eliminating disparities in our county, very invested in this work and see this as a vital tool to identifying the disparities and finding ways to eliminate them creatively. Since this is not the first CHNA conducted by HHS, were you able to assess previous assessments to evaluate trends, what's worked since the implementation of previous plans, what hasn't worked in creating this new needs assessment to see what served populations the best, what didn't, because we have a lot of nonprofits that are addressing the previous needs that were assessed in previous plans.
I'm going to ask my epidemiology team to come up and talk a little bit about Healthy Montgomery core measures and how we update those measures and monitor and track those core measures from kind of CHNA to CHNA.
And as you're sitting down, Ms. Dang, what came to mind is the zip code study that was conducted under Dr. Gales. And when I was on the city council, he came to the Gaithersburg City Council because our zip code ranked one of the lowest in the county. And I know that there were recommendations there. And I just want to know how we are incorporating previous recommendations into this new plan.
Thank you, Councilmember Sales, for that question. Rita Dang, Senior Planning Specialist out of Health Planning Epidemiology within Public Health Services at Department of Health and Human Services. So that's an excellent question. And to Councilmember Sales' last question, we have started the process of actually updating the zip code ranking project report based on recent information that's been received, and also the data that's been coming in from the COVID years will certainly tell a fuller story. But initially, since the last iteration of the community health improvement process, which highlighted priorities such as Eat Well, Be Active, mental health and behavioral health, as well as Healthy All policies, we have come up with actually Healthy Montgomery benchmarks that were consistent and with state local health improvement process out of Maryland State Department of Health, as well as the Healthy People 2020 and Healthy People 2030 goals. And that had a separate document in terms of the Healthy People 2023 goals, in which we published a document that highlighted all of the benchmarks that have been met. Specifically, tuberculosis have actually exceeded the Healthy Montgomery 2023 goals that we've set forth for the county overall. And also, we've gone through this process throughout the course of 2016 and onward to actually take in all of the available evidence and looking at all of the available indicators and measures that are out there measuring population health disease burden, and actually carefully also came up with a set of core measures that are currently on the Healthy Montgomery website, where we track carefully across disease areas such as injury, chronic disease, infectious disease, and also behavioral health, and also others that I can't really remember on the top of my head. But we are tracking that carefully alongside with specific programmatic activities that we have been building on top of since the last iteration of the 2016 Community Health and Needs Assessment. So it's a constant iterative process, and we're also doing this in conjunction, in tandem with the recently released Joint Hospital Community Health and Needs Assessment, which they have been, per IRS guidelines, required to do every 3 years, whereas we do it every 5 to 6 years. Per guidelines for the Public Health Accreditation Board. So all of those are sort of moving pieces, and it's meant to be really an evolving document. But health planning and epidemiology have continued to put out additional data reports that further adds to the evidence of the progress that's been made. And that's also readily available on the Healthy Montgomery website. For example, we recently published a report on the uninsured population within the Montgomery Cares program that highlights data from 2017 to 2022. And we have an independent report of, as Dr. Rogers have mentioned, the first ever primary data survey report that was released in 2022. And we, of course, have the long-standing population health surveillance report that published data from 2010 to 2019. And we're also, as more data comes in from furthermore in advance, like for example, from 2020 on, we're constantly also updating some of the data, for example, across all of the core measures. So I hope that answers the question initially.
Yes, no, it does. It seems like we have a lot of data. We have a lot of nonprofits that are working towards addressing, improving the data. And I think when we get to the CHIP part of this process, since one of the next steps mentioned for the CHNA is to support cross-sector and interagency partnerships and utilizing the CHIP to address the health needs, barriers, issues, and priorities identified by community members. I want to make sure that we are taking all of the prior information into consideration, and also considering what is currently happening with our nonprofits, because any recommendations that are going to be put forth are going to require a budget, and funds are limited. We're already anticipating $1 billion shortfall from the state, and we need to ensure that the programs we're currently funding, if they're not meeting the needs that are set forth in this health improvement process, then we need to reevaluate what we're spending our money on. And, you know, that's what I'm most focused on, making sure that we're talking to the boards, committees, and commissions, because it was mentioned that some of the boards, committees, and commissions may not have been engaged as fully as this needs assessment has outlined. So hopefully they'll be involved in the improvement plan if they're going to be a part of the actual implementation and execution of the recommendations. And then my last question before I get back in the queue, given that transportation and a lack of resources in specific communities are a barrier for our residents, I don't think I saw any work with MDOT or any of our transportation partners to address some of these concerns, but hopefully they will be included in the improvement process.
Yes, thank you for that. Thank you for that question. Montgomery County Department of Transportation is a sector that is represented on Healthy Montgomery Steering Committee. And so we have a representative from MCDOT, Sam, who participated in the voting of the Community Health Needs Assessment. He voted his approval on behalf of Montgomery County DOT. And so we'll continue to make sure that DOT is engaged, as well as the BCCs are engaged on the CHIP process.
Thank you. I yield.
Thank you. Councilmember Lukey.
Thank you. And thank you for, starting out by providing a broad overview of the Healthy Montgomery program. One, and I know we've talked about this before separately, not in a hearing, but I'm wondering how within the Healthy Montgomery initiative, you're using that and its framework to assess the delivery of services that are rendered by our nonprofit partners through contracts through HHS. So could you talk to that a little bit?
Yes, that's a great question. I would say that is out of the scope of Healthy Montgomery.
Okay.
However, I would say that it's important as we develop the Community Health Improvement Plan, as Councilmember Sales articulated, that we look at existing programming across county government as well as across the nonprofit sector to see what assets and resources already exist, so that we're perhaps not duplicating services, but rather strengthening existing services. The Community Health Improvement Plan will also have an evaluation process as a part of it. And so as we develop the CHIP, and then over the next 5 years, we'll be sure to evaluate robustly the effectiveness of the implementation strategies to address those particular priorities.
Because when I'm thinking about, particularly like our minority healthcare programs, which we have multiple, and they do amazing work, and sort of doing a look back at what has been delivered over the past, it's been more than 5 years, right? So from 2016 through now, and then matching what was delivered and what was prioritized in that period of time that matches where you've carried forward now your analysis to what we need to do moving forward, so that the Department of Health and Human Services can realign, hey, this is what we've contracted for in the past, or what we've thought was the priority in the past, but we need to pivot more to this within what we're doing through your initiative, because these are the things that were surfaced in our analysis, and so that's where we need to focus. So just something to keep in mind. There was a slide, and I'm not going to make you put it back up because you had many, but one of them, and it was where you were highlighting the demographic factors that were included, and there were percentages expressed for each kind of different category on that slide about what went into the community health needs assessment. Were the percentages of factors listed on the slide the weight afforded to each category in the analysis, or was that a percentage that represented an expression of the number of elements of the assessment that could properly fall under each category?
So the community engagement metrics, I believe what you're referring to, were the actual number of unique participants that contribute to each data collection element. So, for example, 1,374 individuals participated in the primary survey data. However, our epidemiology team did weight that data so that it can be a representative sample of the Montgomery County community.
Okay, thank you. And then I know you talked about doing oversampling in certain minority communities to enhance the numbers. And I know, we've had conversations along with Councilmember Balcom and Councilmember Friedson about our more rural areas. And what, if anything, was done in the survey in terms of doing the analysis or weighting different things to analyze our more rural zip codes? Or what was the percentage of respondents that were from our more rural zip codes where we know that there are not adequate primary care services, for example, and Poolesville doesn't even have a grocery store. And we also know that area as a whole is impacted greatly by lack of public transit.
Yes, great question. And that goes to the point that in the report we decided to present the findings for each particular subgroup. So we have a section dedicated to the health needs, issues, and barriers that are articulated by residents who live in the agricultural reserves community. And for the quantitative primary survey, 244 individuals participated in that survey. And I believe for the focus groups, I don't have it off the hand, but I think we had probably about 12 or 13, which we would consider for a focus group a valid sample qualitatively.
Yeah, thank you. No, that's great information. I know you mentioned that elevated blood lead levels are decreasing within the county. And just from some of my prior work, I know that there's a correlation between lead remaining in your blood levels, and high fat diets. So where there are food deserts and there's also high lead availability in either the home or the soil, you have a bad concoction, right? That leads to neurotoxicity. Are there other factors? Are there other neurotoxins here in Montgomery County that, combined with those issues where you may have less access to fresh, healthy, whole foods, where higher fat foods are the fast food of choice. As you noted, we don't have, it's very hard to go through a drive-through and get a healthy meal. Do those exist here? If so, what are they?
That's a great question, and I play a lawyer on TV, but not a doctor. So I'm going to see if the good doctor could come up, Dr. Davis, our county health officer, and speak to that.
Thank you. Hi, Dr. Davis.
Hi, good morning. So I can't think of specific examples outside of the one that you've shared of, where that concentration, may be worse. Although I can say I haven't found an opportunity where a high-fat diet is helpful.
Right,
And so
right.
I think, in general, just kind of working to make sure that we're making those healthy options available. But it's something that we continue to look at, especially as we kind of work with our folks in the environmental section on where that kind of overlap is in terms of food and environmental factors and how they can contribute to enhance but more often worsen health outcomes.
Okay. And then last question. I know you mentioned the need for safe and violence-free environments. And that's something that's, very important to me, as just in the past week alone. One of the communities in my district has had a number of episodes and incidents that are causing the residents to say, I can't sleep at night. I don't feel safe in my own house. I feel threatened. And there's a lot of rhetoric around the county that sometimes is in conflict with us providing a safe and violence-free environment. It's not helpful, but it is also a public health issue, as is access to firearms and violence prevention. And so what recommendations do you have from the public health lens on mechanisms for addressing persistent community violence, which is disproportionately affecting our lower income and communities of color?
Yeah, so that was a nice tee up. I can talk about some of the work that we're doing on the Youth Safety Initiative. Have been working a lot with Chief Dara Treadvance and on youth safety initiatives, both within DHHS, but also really across the government and with our nonprofits. And really, it's an opportunity for collaboration with the police department, with MCPS, with many of our other organizations to really look more deeply into what is driving those factors. So there were a lot of efforts that were done this summer to really provide opportunities for youth to be engaged in summer camps and other activities to try and get ahead of that. They have been engaged a consultant who is in the process now of writing a report, and so we hope to have that the end of this year, early next year, that really dives into what are some of those driving factors. We know at a national level that poverty contributes, school contributes. There are a lot of different factors, but they are really looking at what are those factors in Montgomery County so that we can help to plan specifically to what we are experiencing here. So I would say stay tuned, coming soon in terms of what those factors are specifically in our county to try and address the issues that we're seeing.
And thank you for that. And that's definitely on the violence prevention piece. More to the point of, for those communities that are experiencing violence already, where it's on the reaction side, right? So you're left of boom, it's already happened, it's already happening. And there is a persistent detrimental effect on the residents in terms of anxiety, fear, worry, stress. What might we do to assist in that arena for areas where there's already a significant level of that kind of day in, day out trauma?
Yeah, that's a great point, and really thinking about, one, how we think about violence interruption. And so, our street outreach network and positive youth development and doing some of that on the ground community engagement, especially when an event has happened, to really outreach and work with families. And then I know that several of our other community groups are also doing that one-on-one, individual, family, parent support when an interaction happens. So I know Identity has done some of that work, and some of our other nonprofit partners to really help support and wrap around those families. We always want to get at them ahead of when an event happens, but when that unfortunate situation does come into play, we know that there can be ripple effects and continuing violence. And so really getting in there with violence interruption to really help pause that, stop that from cascading into including other individuals.
And what can we do to help victims where it's not an issue of the retaliatory violence, which is definitely a public health and should be dealt with from that perspective. But for those who are victims and are not the ones who are going to be engaging in any retaliatory violence, in fact, they're just afraid. And afraid to speak. And so there's a significant barrier to resolution of the issue if law enforcement, the state's attorney's office says we can't move forward without a witness statement, and you can't be a witness because you're petrified.
Yeah.
What can we do for that population?
I mean, really, the violence issue is a coming together of, many of the different parts of health and human services. So when we think about behavioral health and the crisis center and being able to connect folks up for treatment and mental health therapy to really help process the trauma that has gone on. And so we have resources through the crisis center to help connect folks up, both with folks that take insurance and those that don't, to really help them. There's also partnerships with the school system to really help from that counseling aspect, to be able to, they may see it before anybody calls the crisis center. And so many of our referrals come from the school system that recognize that somebody needs a little bit of an extra touch and an extra helping hand for things specifically like that.
Okay, thank you.
Thank you. I'm glad you're here, Dr. Davis. If you could stay just for a couple of moments. We're all admiring your jacket, by the way. That is beautiful. Perfect fall. Yes. So I guess, where we go from here. We've got, I think, I've seen the previous iterations of this needs assessment, and I feel like this, more than any of the others, maybe even combined, really tells a better story of what's happening. But, it's point in time. And so the question is, what do we do with this information? And I appreciate those last few slides. So I'm going to make a couple of comments and then have a couple of questions. But I would encourage my colleagues in the executive branch, as you bring forth your budget recommendations going into FY25, and this dovetails off of Councilmember Sales's point, directly connecting, if there are enhancements, for example, how that connects to what we've learned from this particular report. So, for example, transportation continues to be a huge barrier. We knew that, we know that, this validates that. And so I would hope that that would then translate into some expansion of mobile opportunities, but also connectivity opportunities, which, and I use that word specifically because, access to internet has public health implications, as we all know, too. So, we drink water from like 5 different fire hoses during the budget process, but I don't want that to be lost in translation this time around. So, in your budget memo over to us, highlighting that and how an investment in these key areas will help address some of the barrier issues, which will lead to better public health, I think would be really helpful to us. Related to that, another comment. So last month, the law that we passed that requires restaurants with kids menus to have a healthy meal option went into effect. And I was really struck by, and I could heard sort of, not the gasps, but the reaction of my colleagues when you mentioned, Dr. Rogers, one of the concerns being the access to healthy food options, which again, we sort of know anecdotally, but now we have quantified information that sort of validates that. And when you have nothing but affordable fast food options, and those fast food options don't often include healthy food, it compounds the problem. So, but the policy that we initiated as a body under the previous council is an example of trying to address those core issues. So I would, again, encourage the administration, as you're looking at, and work with us on recommendations for legislation or policy, which we could introduce as a committee. We could introduce, based on the geographic region, but we have to start thinking expansively in our overall public health infrastructure, and sometimes that translates to the legislative branch. So if there are options or recommendations or stuff that other jurisdictions are doing, we should once again, be a leader in that space, which I think would be really helpful. And now on to the questions as we wrap up. So as you pull the thread on some of the findings, especially over the next 5, 10, 15, 20 years, things like the lowering of birth rate are going to have massive implications from a public health standpoint and a budget standpoint here in Montgomery County. We saw the ups and downs of population increases. We actually turned back significant numbers of schools in the 90s because we had such a decrease in the birth rates. And so, but yet we're investing record numbers of capital improvements in our school system, as we should, based on the needs of today. But I worry that, you pull that thread 5, 10, 15, 20 years from now, there won't be kids in those seats if we continue on this rate. And the reason why people aren't having more children is for a lot of reasons, many of them financial. So could you talk, as one example, could you talk about some of those other indicators, Dr. Davis or Dr. Rogers, that you see in this data that if you pull that thread 5, 10, 15 years from now, it gives you pause or some area of concern, or maybe optimism?
That's a great question. I think there's it's a mouthful, if I could say that. For me, I think it's around dental access. So that I, as a senior administrator in community and population health, I started to oversee our dental area, I think a couple years ago. But the findings from this report that really underscored the lack of dental access across our community has really provided me with a greater commitment, I would say, into prioritizing dental access as a budget item as I look into next fiscal year. We all can have an appreciation for what it means to have healthy teeth. We all can, have an appreciation for what it means to go get our teeth cleaned, get a cavity filled. But so many of our residents don't know how that experience actually feels. And so one thing that I want to take away or champion as a result of this report is really working with our community partners, our safety net providers, to strengthen our safety net dental infrastructure, both for uninsured and underinsured populations. So what was consistent for me throughout the data goes back to those community groups, whether it's based on race, ethnicity, whether it's based on geographic or some other key category. Across the county, we heard from residents from the agricultural reserves on down county that dental access is something that they need. That thing traveled for me throughout this information. So as I kind of peel the curtain back and look back in 5 to 6 years, that's a particular area that I want to ensure that we make progress on, because dental access or dental care impacts maternal and child health, right? Maternal morbidity or mortality. Dental access has an association with transportation or with the environment or healthcare. And so I would say that that's kind of one of my takeaway for this particular CHNA. I would also I don't know if this is a closing moment, but I would also say this to Councilmember Lukey's point in questioning While the community health improvement plan may identify 3 to 5 priority areas, the department is committed to making progress across all of these areas. And so I've been using perpendicular line instead of parallel because these lines intersect. So we're going to be walking perpendicular tracks. And so we'll continue to look back and evaluate, which is why you've heard me share that I'm working with the Commission on Health to look at evaluation capacity across public health services so we could do things just as that is look at our programming to see how we're making progress in each of these areas while we continue to have this community health improvement plan. So all of these 18 areas, as a department under Dr. Bridges' leadership, we're committed to walking these perpendicular tracks.
I definitely agree with dental. Somebody, they asked, when was the last time you hired somebody who was missing a front tooth? Mm-hmm. And just the biases that go along with dental care and how that affects that individual person's economic viability and ability to, just provide for their household is really important. And that theme definitely rang through in the CHNA. Another couple of threads that that stood out for me is you mentioned our decreasing birth rate, but we definitely have an increasing aging population. Mm-hmm. And so when we think long term, how are we preparing for our aging population, helping them to age in place? Again, pulling in our aging and disability folks. How do we help them age healthfully? Do they have access? Do they have the things that they need? Do we have a workforce that supports our aging community? And so that also brings in the thread of it's really difficult and expensive to live here. Yeah. And so how are we creating economic opportunities for folks that are going to be in many of those service roles to provide for our aging community, that they can afford to live here and work here and have the transportation routes that make it easy to be able to help serve our community. The other thing, when we think about our children and that decreasing birth rate, we also have a lot of children. That doesn't tell the whole picture because we have so many children who are coming in from other places and migrants. And so how we think about being welcoming to that community and providing opportunities and taking those kids who may not have had a great educational infrastructure from where they came and getting them to the point where they are graduating high school, that they are productive members of the community, right? Those are the things that are going to help us in the long term. So thinking about those different pockets along the way, that investment that we're making in those kids that are coming in, the investments that we're making so that our communities are aging gracefully and helping make sure that we have that workforce that supports them on both sides.
Thank you. Well said. Councilmember Sales, and then we're going to move on to the next item on the agenda. Councilmember Sales.
Okay, just a quick question about the, I know we talked a lot about the rural communities, up county having a lot of health disparities, and just wanted to better understand the utilization of the Sidney Kramer Up County Clinic, hours of operation, services offered, and how we are increasing awareness and outreach to encourage people to come to that clinic.
Are you referring to the HIV clinic that just opened up county?
Yes. Do we know how many people have been served, or?
No, but we can get that information back to you.
Perfect. And then I may have missed this in the report, but do we know how many of our residents are currently uninsured? I know that there have been a lot of residents who have been rolled off of the health insurance database because of the COVID restrictions have been lifted. And so if we can identify those numbers and how we are connecting them to the resources that we have locally or otherwise.
While Dr. Rogers is looking for that number, I will also highlight the Birth Equity Act. And so the pregnant persons who we were serving in our maternity partnership that now are eligible for Medicaid, that we've had over 1,000 women be able to sign up and transition over to Medicaid, which is a really huge win for them, their babies and their families. We also have seen the state and the Medicaid redetermination. So now folks who their Medicaid wasn't able to, they couldn't come off of the Medicaid rolls during COVID. Now that process has started back up again. Maryland has been taking being very diligent in looking at who remains, who can stay, trying to make that process as easy as possible. Our Office of Eligibility has been doing outreach to folks. The state went through a process earlier this year where some people were falling off the rolls when they shouldn't have been, and so the state paused the process and reinstated their Medicaid and extended the timeline. So other states aren't doing that. I'm really proud of the approach that Maryland has taken in being able to make sure that everybody that can maintain access has the ability to do so.
In the report, something that's just in front of you, you can't see it, but I was able to confirm the county's uninsured rate is 10%, which is lower than the state.
Okay.
And so, Dr. Davis has articulated some of the efforts that we are doing across HHS and county government to get people connected to care, such as Montgomery Cares, Care for Kids, et cetera.
All right. Thank you.
Thank you. It's a good question. I think the underinsurance rate, I think, is also important. And then, we keep touting, I know the county executive has talked about this, that, our unemployment rate is below 2%. That's great, but that is underemployment. That's not unemployment, as we know. So we have to start focusing on that reality. Thank you both so much. Thank you to the team. Thank you to the volunteers. This was an excellent presentation. We look forward to the follow-up. All right, we now move on to the next item on the agenda, which is an update on the implementation of the Federal Emergency Rental Assistance Program. This was a hot topic of conversation by the 19th Council. We, of course, were in the midst of an unprecedented national and international situation. And the good news was we received unprecedented levels of federal funding that we had to work as quickly as humanly possible to set up and disseminate. And I just have to say how proud I am of our Department of Health and Human Services, who became a national model for how and when to do this work. And while there were understandable questions at various points among colleagues, because of the urgency we were all feeling at the time, I think that the system that was set up, was extraordinary. Having said that, it's not without its challenges, and there were obviously a number of lessons learned, and of course we no longer have that federal funding. But we still have a great team in place, and so Ms. Clemens Johnson, I will turn it over to you just to tee this up and speak to this at a high level, and then turn it over to my colleagues in HHS.
All right. I just want to thank you, the team, for coming today. In your staff memorandum, we just highlight the work of the program since it started in May of 2020. This is quote-unquote cycle 5 of the CRRP, and the department took a little bit of a different approach this time, and I'm sure they'll highlight and go through those details, is that with the other iterations of the COVID rent relief program, it was a big announcement, you should apply, submit your applications, and the department this time took more of a strategic approach and used the backing of this funding as just another portion of funding that they're able to fund rent relief. So the education and information to the public has really been like, if you're facing eviction, if you are having troubles paying your rent, come to us and let's talk about your case. And that means that you might get funded through the CRP, you might get funded through county general funds. And so, but they did take a very strategic approach in doing this and conducting focus groups and talking with partners and figuring out the best way to actually assist clients. So there's information in the packet about the budget. We'll talk about that. The program did report that they expect to expend all the state and treasury dollars this year. So I think the our next steps are, what does eviction prevention and rental assistance look like as supported through DHHS and the CEF programs after we no longer have the funding. And so that'll be a new reality for us, as we have had extensive support from the state and feds to do this work. And so I will let the department.
Thank you, Ms. Clemens Johnson. Just a quick logistical check. We're going to try to wrap this session up by around 12:15 if we can, because we have another joint session this afternoon. and that'll give us all an opportunity for an appropriate break in between. But with that, I'm not sure who's presenting first. Dr. Bridgers, I'll turn it over to you.
So, good morning, Council Member Albornoz and HHS Chair, Council Member Sales, and Council Member Lutke. I just wanted to provide some opening remarks to frame the team's presentation this morning. When I became the Director of the Department of Health and Human Services and Ms. Hung joined as its new Chief of Services to End and Prevent Homelessness, we really wanted to take a deeper dive into the CRRP and the ERAP strategy, the policies that were previously set forth by the United States Department of Treasury really didn't speak to the needs of the community. So we really needed to have a process evaluation to look at how we could get the money in the community. Because from looking at the two agencies, the Treasury as compared to big HHS, there were a lot of disparate approaches and policies. And so we really took a deeper dive to make the money more accessible in the community, but we worked closer with our partners at DHCA and other community partners, as you will see in the presentation. There were many lessons learned during the process over the 2 phases, the 4 rounds, and we were not getting the money into the community. So what you will see in this presentation is how we took those lessons learned during the height of COVID and really made them applicable to where we are now, which this is a great segue from the discussion from our community health needs assessment. So that's really the crux of the matter in HHS now, to really look at how we can make a stronger impact in the community. So I promised Ms. Hung I wouldn't sit at the desk and turn it over, but I did want to preface that because the team has put a lot of work into making the money and the resources available across HHS.
Thank you, and I appreciate you highlighting that, because as we were implementing this, we were bound by the federal guidelines. And so there was understandable concerns raised by some, particularly some of the nonprofit organizations and stakeholders, wondering why this was so restrictive, and we were a pass-through. So that's why. So, and I'm glad we looked at that. Ms. Hong, let's turn it over to you.
Thank you so much for your time and attention to this this part of what we do. It's our preventive work. It's stabilizing households in their homes to avoid an experience of homelessness. And I want to thank the housing stabilization team led by Rebecca Sosa, who's sitting next to me. They've done hours of tireless work during the pandemic. With the criteria changing from round to round, they didn't miss a beat. They kept going. They never stopped working, and so I'm so thankful to them for their work. And as Dr. Bridgers mentioned, as I started at CEF in May, one of the first things that I did was to look at how we were spending our remaining ERAP COVID rent relief program funding. And so what we'll talk about today is the strategic decisions we made to impact those households most in need, most at risk of eviction, to prevent experiences of homelessness and to help them gain greater stability. So I'll go through the presentation, and we can, if you have questions afterwards, we'll take those. So the first set of changes we made, because we saw that it was only 29% of households in the COVID rent relief round 4 that were eligible to receive rental assistance. That's a very small number given the rates of evictions that I'll show you later on. So one of the first changes we made was to make the criteria more flexible and inclusive. And as Dr. Bridgers and Tara mentioned, we decided on a more targeted approach. So instead of opening the portal and getting an influx of a huge number of applications, 71% of which were not eligible for the funds, we decided to strategically do outreach to the households that we knew needed it. So this slide represents those changes, and starting on July 17th, we utilized the state funds and we reached out to those households that were below 30% area median income, so our lowest income households, and our team followed up to see if they were in need of additional rental assistance, because the maximum amount that households can receive is 18 months of rental assistance per the ERAP criteria. So we started that in July 17th, and then on August 1st, we rolled out some changes to our treasury funds and how we were distributing those. So we used those to target the households that were receiving eviction judgments, so who were about to be evicted. And again, we targeted households 30% or below AMI because we knew that they were most in need, and the criteria still required that there needed to be a COVID-related hardship as of May 11, 2023, or up to May 11, 2023, and so our goal was to prevent as many evictions as possible by distributing those funds. And again, we were able to distribute up to 18 months of rental assistance. That's a maximum award allowable through the Treasury Department. So our goal very much was to create the flexibility to help more households. Going to the next slide, we further, as we were looking at our spending, we further decided to move our work upstream. We decided we wanted to look at how we could help more households avoid the risk of eviction. So what we decided to do as of October 1st is to make the eligibility criteria for those facing eviction to move the eligibility upstream to when they receive a court summons. So when a landlord it finds that a tenant is late in their rent, they go to the court, and the court will send a summons to the tenant stating, pointing out the late rent, and then the tenant must appear in court. So with the court summons and stating that the eligibility for our assistance happens earlier in the process, that helps households to avoid the trauma of facing eviction, imminent eviction, and it also gives us more time to stabilize them, to provide financial assistance, to provide prevention case management, so that our interventions are more impactful, and it helps prevent households have that eviction judgment on their credit, so that if they need to apply for housing in the future, it doesn't impair their ability as much to gain housing if they choose to relocate. So that was a big change we made as of October 1. And why don't we go to the next slide? I can show you a little bit of the data on eviction in our county over the last 5 fiscal years. So you can see that there's a significant number of households that receive eviction late notices. So these would come to a tenant in the form of a court summons. Prior to the pandemic in FY19, there were about 48,000 households that would get court summons on about related to late rent, and then that declined during the pandemic, I think mostly because of the eviction moratorium. But then as the eviction moratorium ended, then you could see that the late rent notices increased. And for FY24, it was 44,000 late rent notices that went out from the court. You can also see that that the eviction writs received, and that's when the judge decides, okay, so the rent hasn't been paid, we're going to move forward with scheduling an eviction. That's a much smaller percentage of the number of tenants who received eviction notices. And then when you see the number of evictions actually executed, it's an even smaller percentage. This is of interest to us because this is where we try to target our outreach with our community-based partners. So anyone who receives a red and white eviction notice in their home, they are our outreach partners, our community partners, will go to their homes and distribute information about our housing stabilization services. This is provided by the Latino Economic Development Center, the Renters Alliance, as well as the Housing Initiative Partnership. So they're helping us to target our preventive work to all the households who receive the red and white eviction notices and that's a critical part of our outreach efforts. You can also see in the bottom graph how the number of evictions in 2023, they were high at the early part of the year. They've kind of gone up and down and then been steady, but evictions are still occurring, and it underscores the importance of our work that we would continue to provide the housing stabilization services that we offer. Okay, so then let's go to the next slide to talk a little bit more about the financial assistance we've been distributing as well as the work we've been doing. So this is as of October 20th, and the first piece of information I wanted to highlight again is that in the previous and the final round of the COVID rent relief program, that's COVID rent relief round 4, 71% of those who applied were found ineligible. So very stringent criteria. We were concerned that we were not meeting the need of the evictions that that households were facing, as we showed you, and so our goal was to ensure that the rental assistance money, the remaining funds, went to the households who needed it most. So here you can see for the rounds of funding that we started in July, that 34% have been approved and 32% have been found ineligible. That's approximately a 51% approval rate, and we can state that the reasons why the 32% were found ineligible was primarily because they decided to relocate. So we've encountered many households who've had arrearages in the tens of thousands, 10,000 on up to 70,000. And there's a point at which both we and the household must face that sometimes relocation is the best next step. So those 32% that were ineligible, many of those, as I said, who decided to relocate, our team referred them to the next service we provide, which is assistance to relocate, which includes a security deposit and currently 3 months of additional rent. So it wasn't that they were ineligible and they weren't helped. It was that a decision was made that relocation is probably the best step at this point, and so we assisted them with that. The 34% that are under review, that just means that they're currently assigned with our workers and that a decision hasn't been made yet. It's a rolling process, and these numbers reflect that. You can also see that the average award for the remaining ERAP funds is $8,663 per household. And I'm going to talk a little bit about that amount in a later slide, and that we've approved. So it says about close to 3 million, but as of today, it's actually been 4.6 million. So our numbers are we are quickly distributing the funds since we relaxed the eligibility criteria with the court summons as of October 1. You can also see the demographics that have been served, which is consistent with the households that tend to experience housing instability. It's also consistent with the disparity that we see amongst households experiencing homelessness. So it's important to note that we are helping those populations with the rental assistance funds, 49% of which are Black households, 25% are Hispanic, and so on. And then you can also see that it's approximately 70% of the households that are 2 or more in the household, and 31% that are singles. So it's primarily families that we are assisting with our funding. So I think there was okay, I'm sorry. So these are some of the lessons that we learned. Very importantly is that a percentage of residents receiving COVID rent relief, emergency rental assistance, became reliant on the county paying large arrearage balances. And so we would see them during the pandemic returning multiple times seeking assistance. So it became clear to us, knowing that the ERAP dollars would be expended, that we needed to do more longer term prevention work. So oftentimes it's one meeting with a household or phone call, because we do both virtual and in person, to determine, okay, yes, you are eligible or you are not eligible for the financial assistance. Our staff know that there is much more work that needs to be done in order to stabilize the families. That's financial counseling, ongoing, that's connection to resources like employment, behavioral health. So a lot of the feedback I received when I started from the housing stabilization team is that they wanted to do more work. They didn't want to just distribute rental assistance funds. So this is why one of the key lessons learned is that we must invest in longer term prevention case management, and that it's critical for tenants to gain greater self-sufficiency and to be able to sustain their housing. And then also just that our customers find it beneficial to receive services virtually, having that flexibility, because so many of them work during the business hours. So it's hard for them to take time out to come in person. So they really valued and appreciated being able to access the services virtually. And that we need to be flexible in the way that we're engaging and the entry points into our services. Okay, next slide. This is just another set of data showing that, especially after the eviction moratorium and after the eligibility for COVID rent relief was coming to an end, May 11, 2023, that more households were returning for financial assistance. So in FY23, you can see that 8,628 was the total who received financial assistance, and of that number, 1,627 households returned more than once for financial assistance. That's almost 20%, just underscoring the need for more longer-term prevention case management and not just distributing financial assistance. Next slide. Okay, so the numbers. Just amazing to consider that our housing stabilization team distributed over $100 million in emergency rental assistance during the pandemic, and all the work that was done by Amanda Harris and Alana Brand. I want to acknowledge that because it was an incredible feat to build a system, to staff it, and to distribute all of those funds to our county residents. So when I came on board, there was only $13.6 million remaining at the start of FY24, and we allocated $10.8 million of that for ongoing rental assistance, as I described in the previous slides, and then $2.8 million of that was allocated for our COVID rent relief personnel who were staffed up during the pandemic. $3.9 million of the rental assistance funds had been distributed since July, and this was as of mid-October. But as of this morning, I learned that we've distributed $4.6 million in rental assistance. So we are doing a good job distributing the funds that we have. So it says that $6.9 million remains, but it's actually $6.2 million at this point. So that we anticipate we will certainly spend before the end of this fiscal year, given our more relaxed criteria. And there's also a separate ARPA grant that we received for $3.4 million that will also be used to increase the amount of funds available for financial assistance to help stabilize households. And then the next slide is our housing stabilization spending plan with the remaining funds. So as I said, we will target households at risk of eviction and expand assistance in the following ways. We already moved eligibility for assistance from eviction judgment to eviction summons. We increased the maximum amount of financial assistance. We will increase the maximum amount of financial assistance per household from $3,000 to $6,000 annually. This is the county support. So when I mentioned that when a household was found to not be eligible for the remaining ERAP funds, we assisted with relocation. And it had been that we would provide the security deposit in 1 month's rent, but we're moving that to providing the security deposit and 3 months' rent to increase greater stability for the households. And then we're also planning to increase the amount of the maximum amount of utility assistance per household from $2,500 annually to $5,000 annually. And we will increase the housing assistance, I already stated this, from 1 month's rent to 3 months' rent and security deposit, just because we know households need time to build up their savings and to be prepared to take on that rent burden. And then the last slide is our recommended actions. So we believe that we need to ramp up SEF's ability to provide longer-term housing stabilization and prevention case management to help households gain that greater financial stability, as well as maintain funding for the 28 COVID rent relief staff, which are currently term positions. So those positions are not funded beyond fiscal year 24. This is a problem because we just changed our eligibility criteria to serve potentially those 44,000 households that are receiving late rent notices from the court. And we want to maintain, we really need to maintain our ability to meet with and serve that population so that we can continue to distribute the county financial assistance that we have at our disposal, and then do that longer term prevention case management work. So those are our two key recommended actions, and as well as, of course, to increase or maintain the level of county funding for housing stabilization and prevention work in FY25. Yeah, and those are my slides for today.
Wonderful. Again, great work, and I'm happy to hear this next phase in the evolution. Clearly, this wraparound, holistic approach is what we all had been desiring, wanted to get to. We were triaging in real time, during the chaos and confusion, but that is a point that we need to get to. How are we tracking, Ms. Hong, that holistic approach? So in other words, are we tracking those referrals to other county agencies, organizations, the follow-up that comes from those referrals? How are we going to track that moving forward?
Yeah, so part of the challenge in tracking the important and excellent work we do is that we have multiple data systems. SEF utilizes the Homeless Management Information System to track its work in shelter and housing households experiencing homelessness, and it also utilizes the EICM case management database, and they don't currently talk to each other. And then as far as our community partner work, so our community partner work is tracked in our homeless management information system, but as far as the outreach we're providing, I don't believe that's tracked. So it's communicating regularly with our community partners that are doing the outreach. It's receiving data that the sheriff's office can provide us, and then analyzing the data in our case management system. So it's really actually quite challenging, and I didn't have a data manager for the first 4 months that I was in my position. She just started in October, and we're looking at how we can better track data across the different systems, because it's very important for us to be able to understand the work that we're doing and where we need to make improvement, as well as to justify the resources that are coming to us and how we're spending them. I'm going to see if Rebecca has any other comments that she wanted to add about just tracking the work in general.
Sure. So we do track the work, the referrals that we make in the EICM database. And when people come back to us, we can take a look at what referrals were made. Did they follow up? Typically, we work with people for about 30 days. And beyond that, the cases are closed, and we make sure that they have the supports in place that they need. So our case management is short-term.
Thank you. Maybe winter or early spring, we can do a follow-up, Ms. Clemens-Johnson, on that data collection, and that will have given Ms. Hong and her team the time to catch their breath and this new data analyst, and by then I think you'll be in a better position than you are now, understandably, to report out, because I think we have to and Councilmember Sales makes this point all the time correctly, it's important for us to really get a strong assessment of where we've been, and that will track where we're going. And it's worth the time and investment to even hit the pause button as we continue this important work to look internally and administratively so that we have the correct infrastructure in place. We've done it very effectively in the food security space, which I think is a good model, and I think we can do it in this one as well. And this, of course, crosses over into DHCA and some of our partner organizations as well. So it's complex, I get that, but I think it would be great to follow up on that. How are we, so I know, for example, PEPCO and WSSC have a lot of utility assistance programs on their own. How are we making referrals? How are we tracking? Because I appreciated that point that, there has been an increase in need for utility assistance, but how are we connecting to some other existing potential programs that may be available?
Yes, that would be through our Office of Home Energy Programming, and I'm gonna pass that one to Rebecca as well. I think that well, I'm aware that we receive state funding in order to assist in providing utility assistance, and I'm also aware that our community-based providers also can provide some level of assistance as well through the Emergency Assistance Coalition. I do believe that we have the need to increase the amounts that households are in need of, which is why we doubled the cap on emergency assistance that we provide. But I'll pass it to Rebecca if you have any other comments that you wanted to add.
Sure. The utility assistance that our team provides is when somebody is not eligible for OHEP. They were denied OHEP, or maybe they maxed out the benefits that they could get through there. So that's the assistance that our team provides.
Great, thank you. I will yield the colleagues. This time we're going to start with Councilmember Lutke, followed by Councilmember Sales, and I'm going to put myself back in the queue. Councilmember Lutke.
Thank you. I definitely appreciate the work that you've done to make sure that assistance can get to folks earlier in the process, so it's not at the 11th hour. It is a very stressful trajectory within the legal system. A couple of questions. For the Treasury funds that you were discussing, there was a residential requirement that they had to be a county resident for at least 9 months. Is that something that the county imposed, or is that a federal requirement for use of those funds?
That was a county requirement. The Treasury guidelines are pretty flexible, and so we needed to establish what our criteria were that fit within the Treasury guidelines. We did open that up now, starting October 1st. The requirement is just that the individual needs to be a county resident.
Right, yeah. Obviously, if you're getting county funds for rental assistance, it should be for in the county, but it was the durational piece that I was questioning. There was data, and I'm looking, my notes are terrible. I have horrible left-handed person handwriting. You noted in one of your slides that the number of participants receiving service, there was a high percentage of households that were headed by a single Black female with children. And I'm wondering what you're seeing or finding as a nexus between family law related issues that may be coming up that are causing that extra burden on that household, for example, failure to pay child support, and what is done when that comes up or is highlighted as a cause for financial struggle within those households.
Yeah, so definitely one of the things that we've observed on the homeless services side of our work is that households definitely are experiencing a lot of pressure from landlords to pay rents that are rising, and we also saw that a significant number of households were not having their leases renewed. And so we pulled this together. We are looking at patterns of behavior from landlords, but we definitely suspect that there is discrimination where we'll see households basically having to relocate because landlords are not renewing their leases and not giving documentation of reasons why. And this definitely will impact our single parent households. And we know that 60% of the households we serve on the homeless services side of what SEF does are Black households. And they have a variety of expenses that they have to manage on a regular basis. And so that is part of why we're proposing that longer term support, is because we know that the families have competing expenses. It's a very small amount. 30% area median income is a very small amount of funds to manage a household. And we believe that longer term case management will help to both provide the financial counseling, but the connection to other resources that may equip the families to stabilize better, but we also are mindful it's not a lot of income, so they very much need our support.
Right, but like child support payments are not factored into your income for eligibility for different things typically. So you don't. If you receive child support, you're not taxed on the funds you receive as child support. So if a household is missing out on a significant amount of support it's supposed to be receiving, my question is, are you referring them to legal services to help them advocate for that which they are owed under court order already?
Yeah, I'm not aware if we do, but it's certainly something we can look into factoring into our eligibility criteria, because that is a significant amount of the income that would go towards child support. Do you have anything that you'd like to add related to? Okay.
And then I wondered, for the numbers that you showed on the chart that showed like 5 years worth of different evictions data from the notices through those, the much lower number that's actually carried out. Do you know, for the numbers of evictions that are actually carried out, what percentage had received funding through our relief programs and still ended up evicted?
So that's something we would love to know more about. So we receive what we can from the sheriff's office, and they're a great partner in providing the list to us every week of those who are scheduled for eviction, which is very important, because that allows us to not only, as I said, go out to do the outreach to those households directly, but also to be at the court to provide support as well. But no, we don't have that current inoperability between our systems, which I would love to see that happen, because that would enable us to understand our impact on the eviction numbers, which we do believe we are having an impact, but to the extent we don't have the
right.
Yeah.
And I just, in thinking about that too, if you're able to see or say, hey, this is a family, a person we worked with, and we did provide assistance, and they still ended up with eviction, you're able to analyze it and go, what didn't we do, or what could we have done? Where else did they need to be referred to in order to make sure that they were stabilized? So, you may discern patterns from that of those for whom providing the rental assistance is given, but it's still not getting them over the finish line, and they're still ending up in that situation, that we might be able to target better other programming. And then I noticed that there was we had a 54% increase in households receiving financial assistance more than once between fiscal year 22 and fiscal year 23. So we're further out from the height of the COVID pandemic, and yet there's it was a 54% increase. So what do you attribute that to?
I'm sorry, which data set are you?
It was the slide that showed the numbers of households receiving financial assistance more than once, and it was broken out by fiscal year.
I see, between FY22 and FY23. Yes. Yeah, I think that is because we saw also a significant increase in homelessness, a 54% increase in homelessness that, as well. And at the beginning of at the beginning, the latter half of FY23. We do the point in time count in January.
Right.
Yeah, so I believe it's as a result of the rising rent, the lack of the eviction moratorium, which protected
Right.
many families, and then the rising rents we've seen, which is why we're really looking forward to the rent stabilization coming online. I know DHCA is working on what that will look like and waiting to receive, once they publish the guidelines, the public comment. But we are optimistic that that will help, so that families will not need to come and seek assistance multiple times, and as well as the longer term prevention case management we're hoping to be able to provide.
And then in terms of, you mentioned, sometimes they just have to be relocated because the arrears are so substantial.
Yes.
And often in those cases, it's not just the rental arrears that are substantial, it's utilities as well. And so what is done in that circumstance where the debt still exists, the person's relocated and they're no longer in the unit, or no longer using that particular utility provider if they've moved across the boundaries of different utility providers within the county, because we have multiple, but there's still the debt that exists. So are you referring them to bankruptcy counseling to figure out how to discharge debt, and what level of service can they receive as a part of that financial counseling that you, and literacy that you give to help stabilize people?
Yeah, so so much of the time spent by our housing stabilization team very much is reviewing the eligibility of applicants, meeting with them, and it's very short term. That's my point, is that
Right.
they are saying to us, we need to spend more time with these families. So many of them are very young. They need guidance. They need more financial counseling, financial literacy, and we don't have the capacity to provide that. All they have been doing throughout the duration of the pandemic, and even now as we're trying to serve more people, they are processing applications, they're making a determination about how we can assist, we're distributing that financial assistance, but they do not, as far as I know, they do not have the time to then have longer term conversations about the case management conversations about, these are the resources you need, let's sit down and connect you to them.
Right.
So that's what we're asking for, that's what we're seeking, is the ability to do that.
Yeah, because that there's a need for the Band-Aid immediately, but there's still a gaping wound, and that wound's going to follow them and keep growing and keep having problems if all those other aspects of it are not addressed. And then that's not just a problem for them. It then becomes needing higher level services. And at the end of the day, I think everybody wants to feel independent, have a stable home, and be a part of their community, right? So, we need to do that better job more robustly to ensure that we're getting people to where they need to be, if those gaps are existing. So, thank you.
Thank you. Councilmember Sales.
Oh, thank you, Mr. Chair. Just want to thank Dr. Bridgers, Ms. Hong, and Ms. Sosa for the presentation. I want you to know that your work does not go unnoticed, not just by us, but our staff who have to field all of the constituent inquiries regarding homelessness and eviction prevention. So thank you. And I'm glad to see that the presentation concluded with recommendations for moving forward. I don't have a lot of questions since my colleagues did the heavy lifting. But one of the questions I did want to ask, Councilmember Ludke mentioned it, the road to self-sufficiency. I think part of the next steps, since you are going to be spending more time with these clients, is creating a roadmap to self-sufficiency. We all remember when we were in college, and every quarter, every semester, we knew what we needed to do to ensure we were meeting the goals to get our degree. And so it would be helpful to as people are coming to us to ensure that we are all in alignment of what they need to do to reach a road to self-sufficiency, what that looks like, meeting them where they're at, and then providing them with that roadmap. And, you know, you have a committee that is here to support that work, and whatever we can do to support any data collection. But I think that would be really helpful in providing some accountability as well for the clients that are seeking our services, and then us internally looking at all of the resources that we have across HHS, across county government, to ensure that we are checking all of the boxes and they are fully aware of what resources are available to them. Hoping that you mentioned this briefly, that you know, there are some barriers with people who have been evicted with finding suitable homes and having to move, but these issues are going to follow them. And so having some financial classes, or I know that the city of Gaithersburg started the cash campaign. A few of us went over there to celebrate. I think it's been a year since that program's been open, and I'm not sure what the equivalent is to the county, or if the city serves residents outside of the city of Gaithersburg. So that's also going to be helpful for people who need to improve their financial circumstances to secure housing. The last question. No, that's all I have. Thank you.
Great. So obviously this is you know, as we talk about FY25, you know, those 6 million or 6.2 are going to be spent down. And then obviously difficult decisions are going to have to be made going into FY25 and beyond. And so we'll continue to stay at it. And obviously focus on trying to understand what are those underlying issues that are leading to these challenges in the first place, which I know my colleagues and I are very committed to working with the department and all of the key stakeholders and helping to address. But we do need to continue to advocate at the federal and state level, acknowledging that the problem has not gone away. And this is obviously of critical importance and has a direct line to our overall public health. Because this is a significant issue. I had two final questions. Our aging population continues to be our fastest growing demographic, as was noted earlier. On fixed incomes, lots of challenges. How are the numbers bearing out that we're currently seeing in the number of seniors that are in need of rental assistance?
Thank you for your question. So our team has definitely been concerned and pointed out that our shallow subsidy program, which is the county's rental assistance program, it's providing up to $503 a month to residents, was very well utilized by our senior population. A few years back, SEF made the decision to prioritize that funding for households either who have a history of homelessness or who are imminently at risk of homelessness, which was a helpful decision for that population. But then there were so many seniors who relied on that shallow subsidy because they're on a fixed income and needed it, that they were very concerned about their housing stability. So one of the things that we've been working on is ensuring that the senior population has access to that shallow subsidy, the rental assistance program. And so our team is able to make exceptions, you know, to the criteria of imminent risk of homelessness, at imminent risk of homelessness. So it was just making sure that we do prioritize that population for the county rental assistance. So we are doing that now. It's something that I was given feedback about when I started right away by the housing stabilization team. And we do know that the baby boomer population, as they age, that they are very much at risk of experiencing homelessness because of their vulnerability, because of their large numbers. And so we're looking very carefully at how we can support them in our preventive work. The preventive work is something that is so important to all of what CEF does, because if we're not preventing homelessness, then our work will just continue forever. And if we want to reach our goal of ending homelessness, reaching functional zero, we have to make sure our preventive work is as strong, if not stronger, than our work in housing people and our shelter work, which is where I spent the last 17 years. So I'm very familiar with that. But it's been really great to learn about what we can do in the prevention space and to improve it and make sure that we are doing everything we can to prevent households from falling into homelessness.
Great. I'll make that the last word. That was great. Very well said. So Ms. Hong, Ms. Sosa, Dr. Bridgers, thank you all. Ms. Clemens-Johnson, anything else that you wanted to add? No. Great. So with that, the second item on the agenda is over. We are adjourned for this morning.
Thank you.
Thanks a lot.
Thank you.